So we're going to move to theme 3, which is translation to clinical research and clinical practice. The main study that we are presently doing in CAIN theme 3 is a study trying to correlate rates of atherosclerosis progressions in two vascular beds, namely the carotids and the coronaries, and then trying to load the atheroma burden and hopefully composition in both vascular beds at baseline, their rates of progressions with term clinical outcomes. So as you see on this slides, what we are doing, we are recruiting up to 2,000 patients who are scheduled for clinically indicated cath, so invasive coronary angiography. These patients then undergo coronary intravascular ultrasound with virtual histology, and Philippe Lallier mentioned virtual histology this morning, as well as carotid ultrasound examination, both 2D examination for IMT assessment, as well as 3D assessment. David Spence and Aaron Fenster described that for you this morning. Patients undergo these examinations, both IVUS of the coronary, QCA, as well as carotid examinations at baseline and at 24 months. We then follow patients clinically, both for cardiovascular as well as cerebrovascular events, up to 5 years with annual follow-ups. There are a number of sub-studies that have been launched. There is one that is focusing on near-infrared spectroscopy that is led by Philippe Lallier, looking again at the chemical composition of plaques and trying to link that with other imaging modalities. There is a CT sub-study that is jointly led by Ben Chow and Jose Presico, trying to correlate plaque burden on coronary CT versus what we can get by coronary IVUS. There is a third sub-study, which, and I'm certainly not the expert to describe this, but Matthias Friedrich described for you this morning the BOLD technique to assess myocardial oxygenation. So we are looking at correlations between BOLD-determined myocardial oxygenation using CMR versus fractional flow reserve, as well as the other coronary imaging modalities. We are also collecting bloods for both plasma and DNA to look at genomics, pharmacogenomics, and other omic technologies. I won't go into all the details. And as you'll see later on, this is actually a nice framework to then run clinical trials of novel anti-atherosclerotic agents. And we are actually doing that in CAIN 3, as most of you are aware. So why IVUS? So very briefly, we're going to zip through these slides quickly. IVUS is a real-time, high-resolution imaging modality. It is, however, invasive. It allows visualization of the entire circumference of the vessel wall, allowing both the assessment of the lumen, of plaque, as well as the remodeling of the vessel that's been mentioned this morning. And certainly, we think it can provide important insights into the effects of treatments. So IVUS detects atheroma that is not apparent on angiography. You can see on the, can you turn off the light?
I can't. I just don't understand how the light switch is working.
So we need central black. Okay, good. Actually, it's really a shame. I understand what the other speakers were saying. The images look beautiful here and they look terrible there. Anyway, IVUS does detect atheroma that are not apparent on angiography. It also reveals the diffuse nature of atherosclerosis. Rob Hammond mentioned this morning. And when you start doing vascular wall imaging, once there is one mild stenosis on angiography, as you can see on the left panel, then almost invariably all of the cross sections are occupied by plaque. The other concept also is that IVUS not only allows you to look at plaque burden, it also quantifies an integral process in the progression of atherosclerosis, or the evolution of the atherosclerotic process, which is vascular remodeling. As you see on this slide, actually the site of stenosis, which is more distal on the left panel, actually has a bigger total vessel dimension than the proximal so-called reference segment. And this is in vivo evidence of adaptive vascular remodeling to accommodate the plaque and to keep a lumen that is at least open. The other advantage of IVUS is that it does allow you to detect regression of disease. This is a patient, the same cross-section 2 years apart. You see that little branch at 7 o'clock, the large branch at 11 o'clock. And while the image quality is not good because of this, the system here, you actually see, if you look at the numbers, that despite quite large and dramatic reductions in plaque burden, actually the lumen is not changed too much, because we now know with IVUS that vascular remodeling is a bidirectional phenomenon. It is when plaque is shrinking, total vessel dimensions are coming down, as you see the number here, and hence the lumen assessment will tend to underestimate changes in the vascular wall. Actually, I'm going to skip this. Some people have taken this, as Philippe Lallier said this morning, to say, well, if the correlation is not good between lumen and vascular wall, maybe there's no point in actually looking at the lumen because QCA and IVUS do not correlate. This is actually incorrect. Philippe mentioned that this morning. We've correlated QCA and IVUS in 500 patients imaged twice, 2 years apart. So this is IVUS and QCA at baseline, IVUS and QCA 2 years later. And there are two messages here. We've dichotomized the patients into, in green, those patients that had angiographic evidence of progression of disease, and in yellow, those patients without angiographic evidence of progression of disease. And on the y-axis, you have mean plaque volume on IVUS. So you have two messages here that are reassuring. A, those patients who have angiographic progression of disease have bigger plaque volumes on IVUS, which is reassuring. And B, those same patients that have angiographic progression also progress more on IVUS. So while the relationships are imperfect, there are significant relationships between IVUS and QCA. And the reason I'm mentioning this is that actually, as Evelyn mentioned this morning, the problem with some of the imaging modalities is that their links with future outcomes, which at the end of the day, what really matters for clinicians, are either well delineated or have not been tested adequately. But at least QCA has been around for 40 years, and we know that if you do have angiographic evidence of progression of disease, you're going to have more coronary events. This is a study 20 years ago by David Waters when he was at the Montreal Heart Institute. So if QCA correlates or predicts future events, and IVUS at least has some level of evidence correlating it with QCA, probably one would hope that IVUS changes over time are going to predict outcomes. We're not there yet, and that's why we're doing this study. What we have right now in 2011 actually linking IVUS and outcomes is pretty limited. We have indirect evidence linking an IVUS study reversal where the more intensive statin approach yielded better results on IVUS, and the same statin at the same dosage resulted in better clinical outcomes. But these are not the same patients, not the same setting, so these results are really quite limited. Both the Cleveland Clinic and our group have some results from some small study populations where we have linked IVUS with future outcomes, but this is still pretty limited in terms of evidence. So we need more data, and again, that's why we do this study. We're doing this study. How we measure these parameters on IVUS, I think most of you are aware. So we trace the blood to intima interface to determine lumen area, and then the media to adventitia interface, which we call the EEM. And basically the difference between the EEM and lumen is basically plaque. If you stack up these images over a given length, you get lumen volume, total vessel volume, and plaque volume. And then we reconstruct this over a given length and using fixed anatomical landmarks to make sure we compare apples to apples with images 2 years apart. And typically these fixed landmarks are arterial branches that we use. I won't go into all of the details of the endpoints. Suffice to say we look pretty much at all the parameters that you can look at with IVUS, both in terms of lumen changes, plaque changes, and remodeling changes, chronic changes in the EEM. I'll just say one word about what we call PAV, or percent atheroma volume, because it's actually one of the co-primary endpoints. PAV is actually the percentage of total dimensions occupied by plaque. So in terms of the maths, you simply divide atheroma volume by EEM volume. You compute that at baseline and follow-up, and the difference between the two is obviously the change in PAV. One reminder, because we still hear that question, IVUS is an invasive technique, but actually there are several studies that have shown that it is a safe technique when performed by people who are expert at this. There are both studies reporting the short-term safety and the long-term safety. In terms of the long-term safety, this is a study we did some years ago, 500 patients, where we repeated evaluations 2 years later. We compared the patient being his own control, the IVUS instrumented vessel versus the non-instrumented vessel, and there was no evidence of accelerated atherosclerosis. We've done IVUS in a bunch of studies. I won't go into all the details. Sometimes you would have preferred in these randomized trials to be in the placebo group, but the point being that IVUS was able actually to help to decide which drug should be moved forward to phase 3 and which drug should be killed. I won't go into all the details, but despite all the good animal data that were generated with ACAT inhibitors, there have been a number of imaging studies showing that it actually accelerated atherosclerosis. So that line of investigation has been abandoned. Just one other example that's more dramatic. We also use IVUS to assess rapid regression of disease using HDL infusions. I won't go into all the details, but in non-definitive studies, small studies, we were able to demonstrate both favorable changes in plaque burden as well as plaque composition with these HDL infusions. And several of you are aware and are actually participating now in the largest study ever of HDL infusions that we're running in Canada. It's called CAIN. Can HDL infusions significantly quicken atherosclerosis regression? I'm going to skip this, and then I'll just say 2 words. The second modality that we're using in the carotid circulation is ultrasonography, both 2D IMT and 3D plaques. I will not say anything because Eva gave a superb talk this morning about this. We know that this is a robust technique, both linking in terms of the epidemiology, and she's shown you all the studies, but IMT does predict future outcomes, both in the coronary circulation, MIs, as well as in the carotid circulation, strokes. And it has been used to test pharmacological interventions. And the reason I'm showing this intervention is going to be obvious in 5 minutes. IMT has been used to actually test HDL-raising drugs. I'll come back to that in a minute. So as far as the actual inclusion-exclusion criteria for Project 3 are concerned, as I said earlier, patients need to be scheduled for clinically indicated cath with or without ad hoc PCI. Because of the slides I showed you earlier, the point being, if you have at least one narrowing of at least 20% on the angiogram, we know there'll be plenty of plaque on IVUS, so this is why you have this inclusion criterion. And we also need to have at least one target coronary artery for IVUS that has not been influenced by prior or present PCI and that has not been the cause of a recent MI. And for obvious reason, we do not want patients with tight left main coronary artery because typically they'll need an intervention. In terms of the target coronary artery, IVUS is used here as a research procedure, so we certainly do not want to harm a patient. So we're using it in vessels that do not have tight lesions, vessels that are fairly large to accommodate the catheter, obviously vessels that are free of filling defects to avoid embolization distally, and again, vessels that have not been intervened during the present procedure or in the past. 2 co-primary endpoints, one in the coronary circulation. So the coronary co-primary endpoint in CAIN Project 3 is the nominal change in PAV. I mentioned what PAV is a few minutes ago. And the carotid co-primary endpoint is the nominal change in mean IMT. And again, Eva described this morning. I won't go into the long list of other imaging endpoints. I will just point out that we all are interested in plaque characterization and including virtual histology. So it is actually going to be the first study ever looking at changes over time in virtual histology indices and links with future outcomes, as well as a number of 3D volumetric assessments, and David Spence and Aaron Fenster described them, changes in vessel wall volume and plaque volume. I said we're trying to link imaging, both in the coronary circulation and the carotid circulation, with future outcomes. So we're looking pretty much at all vascular endpoints you can imagine, up to 5 years. So death, MI, stroke, unstable angina, TIAs, revascs, and surgical revascularizations. What I think is also interesting, out of the cohort that is being observed in the main CAIN Project 3, there is a subset of patients in a sister study called DALPLAC 2. 900 patients using the same framework are being randomized to either an HDL-raising drug, and I won't go into all the details, dalcitripib or placebo. It is basically the same imaging investigations by and large, except the fact that because CIMT is not invasive, we are actually adding other CIMT evaluations at 6 and 12 months on top of the baseline and 24 months evaluations. And obviously these patients are randomized on top of standard of care. The primary objective of the DALPLAC 2 study is to evaluate the effect of dalcitripib over 2 years on rates of atherosclerosis progression using both coronary IVUS and carotid ultrasonography. It is really the first study ever, and I think we should be very proud of that, the first study ever testing a novel, potentially anti-atherosclerotic agent in 2 vascular beds in the same patients at the same time. The inclusion-exclusion criteria are almost identical. There is one exception. Eva mentioned this morning the ENHANCE study and mentioned that one of the potential problems was that these patients did not have enough plaque to start with. So we have at least minimum requirements for presence of plaque in the carotid circulation so that at least we will have enough plaque to start with to see a treatment effect. And in terms of the exclusion criteria, no big differences versus those I mentioned for CAIN Project 3. 2 co-primary endpoints in DALPLAC 2. Again, the same ones as in CAIN Project 3. The nominal change over 2 years in coronary PAV. And the other co-primary endpoint in the carotid circulation, the rate of change from baseline to 24 months in mean IMT that is measured, one thing I did not mention up to now, in both the far walls of the right and left common carotid bulb, and internal carotid artery. And Eva mentioned this morning this controversy. Some people just focus on the common carotid, where the analysis is simpler, but there's actually more atheroma burden in the internal carotid artery. So we're looking at these 6 sites in DALPLAC 2. And then we're looking at a number of secondary and exploratory imaging endpoints. I will not go into all the details, but suffice it to say that we are also looking at coronary QCA in this study, not only coronary IVUS and carotid ultrasounds, for two reasons. A, QCA allows you to look at all 3 coronary arteries, unlike IVUS where we're focusing on one vessel. And second, we tend to be careful with IVUS. We tend to look at the proximal part of epicardial arteries, whereas QCA allows you to look at also the distal vascular bed. And so one of the things that are interesting, I think, in terms of methodology of DALPLAC 2 is that we're not only looking at baseline in 24 months, but we're also doing serial examinations, and we may be able to see, hopefully, that an HDL-raising drug will actually induce rapid regression of disease. So in summary, what CAIN Project 3 is an attempt to correlate rates of atherosclerosis progression in coronary and carotid arteries and trying to link those with future clinical outcomes in 2,000 patients, a number of sub-studies that I mentioned, and we think that this is a nice framework for future clinical trials. Thank you for your attention.